recipients of this year's Representative Paul Luebke Legislative Championship on Mental Health Award are Senator Tamara Berenger and Senator Tommy Tucker, and I'd like to ask them to come join me on the stage. Senator Tucker and Senator Berenger are being recognized today for several years' worth of work in the legislature on important mental health issues, including last year's successes with Ryland's Law, a law that will overhaul our foster care system and make sure that we set a standard for foster care being provided across 100 counties in a way that has high quality of service, consistent service no matter where a child lives, transparent way of doing business, and a reliable delivery mechanism for support. One thing that I would personally like to recognize both Senator Tucker and Senator Berenger for is that they are both very good at taking quiet issues and making them loud. We know that for too many reasons, mental health does not get discussed loudly enough in this society. Foster children are too often ignored. There are too many people that we care about in our lives or that we care for in our service whose voices are simply not heard, whose challenges are not recognized by people who have the most power to do good things for them. And it takes people like Senator Berenger and Senator Tucker who are willing to do very hard, very gritty work in the legislature to take an issue that most people are all too comfortable avoiding and make enough noise about it that they can get major legislation done. I'm very proud to serve with them and would really like to congratulate them on the awards. They are being given these beautiful State of North Carolina plaques made by Josh's Hope. Congratulations to the
Thank you, Representative Meyer. What wonderful things you said about us. I'd like to take a minute to tell you a little bit about myself. I know some of you in the room and some of you know me, but I have an awful lot of passion for these issues, and I'd like for you to understand why. I'm from a very modest background. My first home didn't have indoor plumbing. My dad lost everything, or our family lost everything in an uninsured tobacco barn fire in 1960 when I was 2 years old. And the wonderful thing about it is I grew up pretty much in poverty for the first 5 years of my life, and I didn't even realize it till just a couple of years ago. And what a blessing. And I thought about it. Why? How could that happen? How could I, from this very modest background, end up getting to be a professor at a world-class university, get to serve in the North Carolina Senate? And there are many factors, but the big one was a strong, loving, healthy family. That defines me and defines everything that I do. Make a difference. My husband Brent is here today. He's going to go, he'll be leaving in a little bit because our daughter's prom is tonight and he's going to be the chef for the breakfast. So he's got to go to the grocery store. But when we had the opportunity to serve, we became therapeutic foster parents with the Methodist Home for Children for 10 years. And boy, did that open our hearts and open our eyes. We had children in our home that had been brutalized. One child had been strapped in a car seat, locked in a dark closet, and I can only imagine her screams while the people that were supposed to love her the most were right outside the door ignoring her. We also had a child in our home that had been life-flighted to Chapel Hill, so brutalized with multiple broken bones. They thought she had been shaken, and thankfully she had not, but at not even 3 months old, she had also been sexually abused. And I think the worst thing of all, besides the cracked skull and all the physical harm, was that she did not want people to touch her. She was the easiest baby to put down because she didn't want to be cuddled at night, because to her, human contact did not have the meaning that it should have had. We had others in our home. We had a very large, and still do, circle of friends who were foster parents. And one of the things that I discovered in this situation was, I don't think there was a single family that did not either have a mental illness issue or a substance use disability, or frankly, it was usually both. And so when I had the opportunity to come to the General Assembly, my husband and I agreed that we would take this on. It's a whole family thing. And I do not sleep at night because I'm haunted by those visions of those children. And I get up early because I'm haunted by those visions of those children. But when I got to the General Assembly, I was just this one girl senator with a big old smile and a whole lot of really ambitious ideas. And little did I know that I was going to meet Senator Tommy Tucker. We are the most unlikely pair, I would think, although as we got to know each other, there's really a lot more in common there than we know. I want you to know that every piece of legislation that I took to his office, and let me tell you, they were considered, I think, probably harebrained schemes. I wanted to extend foster care to 21. I might as well have had 3 heads when I started talking about that. This whole business of restructuring the Department of Health and Human Services, not just for foster children, but for the aged and the elderly and the vulnerable and those with mental health and substance use issues across this state, that set people's hair on fire. Let me tell you that every time I would go to his office and ask for his help, he did not hesitate. I would hand the bill across the table and he'd put his name on it. And then he and I together would begin fighting for that. And I'd often at night, when I was having those nights that I couldn't sleep, I would imagine, because this man has had my back. He's had my back for 6 years. And that phrase comes from the medieval times when people actually fought with swords and you fought back to back so that you didn't have a vulnerable place. You were covered. You were covered. And this man has been covered for me. He's also taught me to be louder. I think what Representative Meyer said was so true. I can remember when I was championing the PRTF education issue for children. You know, before that, in this state, if you were in Duke University Hospital or if you were in Chapel Hill or Wake Med or wherever it was, a teacher would be sent to you, but if you were at a psychiatric residential treatment facility, those children did not have educational opportunities. They do now, and one of the reasons they do now is this man standing behind me. And the reason for that is one day I got in a dust-up out in the hall with someone who was trying to tell me that a PRTF was a private school and we should not be educating those children. Yes, it is laughable. It's ridiculous. Well, I'm of course not having any of that in a full dust-up. And he happens to walk by and I see him in the corner of my eye and I'm thinking, oh, here comes the cavalry. Senator Tucker's going to come in. And well, he just kept walking. And it took my breath. And for a minute, I lost my train of thought. And then I realized, as he said so many other times, that he said it with his actions and not his words. He was saying, Berenger, you've got this. You got this, Berenger. And sure enough, we did. I cannot say enough. He's the most humble man. He would never let me tell him these things. So I wanted to share it with you. I want you to know just how great it is. He has announced his retirement. And now he thinks that I'm not going to be plopping in his office and sitting down and he's going to say, all right, Berenger, what is it this time? But I've got him on speed dial. And so I know, and there have been times when we were making all that noise, he would say things like, Berenger, there's blood and water. I know there's blood and water, but you know what? We've got this. We've got this. You've got this. Well, Senator Tucker, when I call you up, you're going to have to say that again because I'm not going to give this up. You're not going to give this up. And we're going to keep doing this together and with all of y'all. So it's the greatest honor, and I'm so humbled and so gratified that you would recognize me in such a wonderful way. But I'll tell you the thing that means the most to me is to get to share this award with the man that has mentored me all these years. That's the real honor that I have. So thank you so much, and I now yield to the champion of the vulnerable, Senator Tommy Tucker.
It is great to be here this morning. It is tremendous having attended NC State. I can think of no other place I'd rather be on a Saturday morning than Chapel Hill. Actually, the Lord has worked on me. All my friends now later in life, as bad as I hated Chapel Hill when I was a teenager in my early 20s, when Coach Smith was winning all the ball games and my high school sweetheart married a Carolina basketball player, I got people to work with like a UNC law professor. Let me tell you about her. She's a workhorse. She puts all these bills together, the ABLE Act, Ryan's Law, foster care. But she's not only puts the words to paper, she takes the passion to paper as well, to make a difference and to make something happen for the least of these. And she is the champion for the children and champion for all the causes that she takes on. It's been my honor to be with her and I felt like I was playing football again because all the time she asked me to run interference for her. But it's okay. We have certainly enjoyed it. You know, we're all human beings in the legislature and we bring life's experiences to the legislature. I cannot believe I'm standing here as a senator and in front of all you folks to speak this morning. I grew up in Eastern North Carolina. My dad suffered from PTSD from World War II. He was an abusive alcoholic. And so I grew up with the lights being turned out, the water being turned off, the gas being turned off, the foreclosure on the house, the running out of the house at 2 in the morning when my mother and father were fighting and neighbors coming to pick us up to have a place to stay. And I can tell you that the impact on children is unbelievable. I left that family environment very dysfunctional. With a big chip on my shoulder. Floyd McKissick tells me some days it's still there. You know, I grew up in that environment, and then with no understanding, my mom had fought cancer. She died in November '65, and then my father died 3 months later of cirrhosis of the liver right in Durham at the VA hospital. And so there's my sister and I. There we are left with nothing. My father didn't have any money, he'd spent it all. We didn't have a place to stay. The Methodist Church paid for me to go to military school in Virginia, so I left home when I was 15. But I'm a survivor. And so that's what I bring when I talk to someone about mental health. I've had to deal with it myself. I've had to go to counseling myself. I was a big-time drinker in college. It cost me a college education and a party guy. And right on up until the Lord got a hold of me when I was 30 years old and turned me around. So I say to you that when we get involved in this, she's lived it and I've lived it. I have someone in my immediate family in 1980 who went to Morganton to the state hospital with mental health. And that back then, it was 1-800-GOOD-LUCK-RALEIGH. Because you couldn't get a response about mental health. That's changed today. That's changed today through the efforts of Dr. Cohen and Dave Richards and their staff and all the great employees of the LME MCOs. I can't tell you how our phone has stopped ringing because of the work you do and the people you serve. It's a daunting task. But we must continue. With 25 million people with opioid crisis and the dysfunction that reaches out and touches all those families and the problems that prevail, folks in this room and the people you serve and your consumers that take upon your services are key to our society making a turn. It's a great honor to be honored with the Paul Lutke Award. I served with him a brief time before he passed away. I served with Tamara and I served with those folks in DHHS. And let me say, folks, while things seem dim, DHHS is a heck of a lot better than when I got there in 2011. I can tell you that. Dr. Cohen and I share a great relationship, even though she's a good Democrat. No, she has respect for the legislature. I've been through 4 health directors, and she is the most knowledgeable out of the 4 that we've had there. And you know, my tact is a little bit blustery sometimes, and the first time I met her, I fired at her, and she came right back at me, and then I was laughing about it, and the guy told me, he said, well, you think you're gonna catch her off guard? She testified before Congress when she was 8 months old, like 8 months pregnant, and made that congressman look like toast. So you're not gonna bother her. Dave Richards, when we birthed the LME MCOs, I told him I'd never bring it up again, but he was head of the ARC and he thought I was crazy. But I can tell you the LME MCOs will be around, and we'll talk about that later. But I am so very grateful for all of you professionals who serve the least of these. It must be a mission. It must be a heartfelt passion, and it's critical to this nation that you continue. Thank you very much.
Senator Tucker, a lot of my friends who are Democrats, as you just said, have been having conversations about who's the next president going to be, and you might have just picked up a few votes. It's great. We're going to move ahead in the agenda to the Lived Experiences panel, and I'd like to invite Megan Gifford and Darnell Wilson to join me on the stage. Megan's also doing double duty today as part of our media team, live streaming the event. You get to live stream yourself. This is fun. Let me introduce you to these fine people. Megan Gifford is the mother of 3 children, including 1 child on the autism spectrum and 1 child living with cystic fibrosis. In addition to having to navigate medical and mental health treatment providers for her children's needs, she is a community advocate who volunteers her time to help others in the special needs community. Darnell Wilson is a 56-year-old African-American man who lives with major depression and congestive heart failure, as well as other medical needs. He has also experienced homelessness and unemployment in his life. Darnell is passionate about his involvement with the Seventh-day Adventist Church, committed to serving his church community and volunteering weekly at the men's shelter. I think we've got both of them here, and I don't know who's going first, but you're going to hear about
first. I'm just going to adjust this last stream to focus on myself. So, as Greg said, my name is Megan Gifford, and I have been taking photos at this event for a long time, maybe 5 or 6 years. So that's why some of you recognize me if you can't place the face. So this also means that for most of you who attend this event every year, I have pictures of you eating. So I want you to remember that when you're filling out your evaluations at the end, because I'll consider it as I'm posting your photos later in the day, whether you get your fun photo booth pictures taken or, you know, the one with your mouth full of bacon. So totally up to you.
Say what now?
All right, so I live in Hillsborough with my husband, and we have 3 kids. So our son James is 11, Ross is 21 and has high-functioning autism and ADHD, anxiety, and also struggles with depression. My daughter Madison is a 24-year-old ICU nurse with cystic fibrosis. You can see her wedding pictures are here. That's the whole family. So Madison's battled anxiety almost her entire life. As you can imagine, being born with a terminal illness is not super fun. And she has endured a lot in her short time on this earth. So, in addition to Madison, you know, she's in good company. My mother has multiple sclerosis, and she also battled depression when I was a child. That was pretty severe. My grandmother literally died of bipolar disorder. She had some delusions of grandeur that prevented her from seeking appropriate medical care for a condition that was easily treatable, and she died when she was 51. So, then there's me. So I know that we make a lot of judgments just based on what we see or the way that people carry themselves. So allow me to just totally blow that out of the water for you right now. I might look like I'm put together. I hope I look like I'm put together. Everything I'm wearing except for my earrings came from Goodwill. I had 3 hours of sleep last night. And I've also had cancer twice. And my thyroid cancer resulted in a combo of medications that has induced pretty severe anxiety and even panic attacks, doing things that I used to really enjoy and not having any problem with. So I could easily talk to you about integrated care all day as it relates to members of my immediate family. But today I want to talk to you a little bit about my daughter, because I have a story that I think is pretty illustrative of some of the challenges that we face as mental health advocates. So this was back in December of 2014. She was a sophomore in college, and she went for a tune-up sinus surgery during winter break for her cystic fibrosis. So I waited longer than usual in the waiting room that day, and a full hour after she was out of surgery, there was an irritated nurse who came and got me to take me back. So we're walking down this long hallway, and she just turns and says to me, "Someone is not happy. We're hoping you can calm her down." So my heart just sank because I realized that the screaming sounds that were whispered at the start of this walk would just get louder until I met the eyes of my daughter. There is nothing really that can prepare you to see your child in complete agony. She was sobbing, she was whimpering like an injured puppy, and every 30 seconds or so she would just let out a blood-curdling scream. So I had a lot of emotions at that point in time that were not G-rated, but I knew I had to keep it together. And so I just turned and said, "I'm not sure what you expect me to do. She's clearly in extreme pain, and what have you given her?" They said, "Well, we're giving her a prescription for Vicodin to take home because, we can't give her IV pain meds because she's going home with you tonight." It was a Friday night, like 6 o'clock. She said, "But, we're going to ask them to order some Klonopin because she's having a lot of anxiety." And that just hit me like a ton of bricks, because there it was. And I don't know why I was surprised, because I already knew a lot of people are really reluctant to accept a mental health diagnosis or even share that mental health diagnosis with a primary care doctor because it means you're inevitably treated differently. They only have 20 minutes, 15 minutes with a patient, and they're expected to solve really complex problems sometimes. And when the symptoms have multiple differential diagnoses and the patient has a history of mental illness that overlaps with some of those symptoms, it's easy to write it off to a mental health disorder when preliminary tests aren't conclusive. In my daughter's case, they assumed that because she was taking an anti-anxiety medicine, that her pain was a result of that anxiety. And I had to explain to them that she wouldn't even take Advil for migraines because the rebound headaches were so bad. I also had to explain that because of cystic fibrosis, that anything they gave her orally, she wasn't going to metabolize the same way that a normal person would. So, as it turned out, that day they had drilled away quite a bit of the bone in her skull to clean her sinuses out. And coming out of anesthesia, she'd been doing nothing for the pain. So by this time, everybody in the PACU was gone, except for us, a nurse, and a respiratory therapist. And it was 23 minutes from my arrival in the room, or about an hour and a half after her surgery, that she was finally given pain medicine. And I know that because I was recording the whole thing. So this, unfortunately, is not an isolated incident, and it's not specific to my daughter. I experienced something really similar as an inpatient for 3 days, which led to PSD. I would just cry until I passed out. And my husband, who is a healthcare provider, just laid down and cried beside me. At the age of 37, I was given Prozac for extreme fatigue and muscle pain. And come to find out, I actually had mono. I had to beg for that test because my son got diagnosed with it, and I said, "Hey, my 14-year-old has mono, I think that might be it." And he said, "You're 37 years old, ma'am, but with all due respect, there's no way you haven't had it." And I thought I had it in high school anyway, but so I said, "Just humor me. Just humor me and do the test, and let's rule it out because I just don't feel like anything's helping." And so he did the test, and he came back in, he's like, yeah, mono. And that was, confirmed by the viral capsid antigen and not just the monospot for the physicians in the room. So he said, I don't know what you need me for. And I said, "I just need you to stand there and look pretty." So, he's very handsome, my doctor, just so you know. I'll give you his name later. Anyway. And he's recently single, ladies. So, 6 months ago, I had a specialist tell me to accept my seriously impaired cognitive function, weight gain, extreme fatigue, and exercise intolerance as my new normal. So I persisted, and another doctor who was just throwing things at the wall to see what would stick, so to speak, found out that my growth hormone levels were lower than the mean for an 80-year-old woman. What are the symptoms of that disorder? Impaired cognitive function, weight gain, fatigue, and exercise intolerance. So I am not a person who is shamed by the stigma of mental illness. I just believe in being yourself and letting that fly. And if you stop at the photo booth, you're gonna see that I have no shame at all because I brought all that stuff from my house. But every time I see a new doctor, I'm noted as being anxious. Even after producing a chart that would be impressive for an 80-year-old. Of course I'm anxious. I know there's a good chance they're not gonna believe anything that I'm saying because my chart says I'm anxious. What I'm really anxious for is the day when I don't have to worry about my mental health diagnosis impacting the care that I receive for the rest of my body. And I really hope that my daughter, thank you. I really, really hope that my daughter lives to see that day as well. So, you got it.
I gotta go over that, you know? Good morning, everybody. My name is Darnell Wilson. Oh, that's my beautiful mother up there. I give honor to my mother. She's been gone for 36 years. And I look at that picture, I kind of smile at it. But before I get to talking, let me thank you, my support group. That's my Lord and Savior, Jesus Christ. My church, the Raleigh Seventh-day Adventist Church, Easter Seals, and Max, I mentioned your name. Can you take me home, Max? I want to walk, man. But okay, since I got that out the way, I'm going to talk about the monkey that's on my back. We're scared to talk about it. That's depression. It's a silent, miserable, rotten thing that just follows you around. And I'm kind of a blunt person when it comes to talking about depression. It kind of sucks. Don't nobody want to talk about it. It brings your body down, brings your health down, it brings you down personally. And it has done its damage to me. It's brought my health down. I have congestive heart failure. I suffer with diabetes. I suffer with gout. My mobility is shot. I have given up, sometimes I've given up on myself. God has been good to me. I didn't need to take any medications. I thank God I had a good therapist and I learned how to pray and that got me through it. The medications don't hit me too well. And let me talk about the mental health system. Going back and forth to the doctor is one thing, but if you got a doctor that doesn't have compassion, the word compassion, I've been in and out of doctor's offices just because I didn't have a copay. I went the other day, my doctor sent me the other day to get an MRI. Maybe my mathematics is wrong. I had $3.55. I talked to the receptionist, mentioned compassion. I said, let me see, Mr. Wilson. That's all I have. She said, well, let me go back in the back and talk to my manager. The manager came out and said to me, we cannot see you, Mr. Wilson. Go out in the lobby and see if you can get 45 cents. That's kind of funny, isn't it, you know? Maybe my mathematics is wrong, you know. You're going to throw me out the door and have MRI is almost $8,000. You know what I mean? Am I correct? You know what I mean? I'm just wondering in my mind, you know, you're going to give up $8,000 for 45 cents. You know, maybe I didn't go to school long enough. I should have stayed in college, or I should have been in math. Maybe I'm sorry, Mom. I'm sorry. You know, so I'm sorry. Forgive me, Mother. You know, I should have. You know, my education should help me now, but that bothers me. And the word compassion comes into that quite a bit. Now, let me talk about the fellows that are. Let me talk about the homeless that are in the street. You take this kind of a harsh and cold. Ever since they shut Dorothea Dix down, they have kicked these brothers hard. They have stepped on them, they have embarrassed them, they have made them feel like second-class citizens in the street. And frankly, you talk about straightening out the homelessness in Raleigh, all they've done is take off Moore Square and took all the seats out of Moore Square. They don't want them down there. And these guys cannot see a doctor. These guys they got worse than what I got. Bipolar problem, schizophrenia. If these guys can't pay their copay, they get kicked to the curb. And these brothers out here with these kind of conditions, they are dangerous in the street. We need to have compassion. Compassion goes from the receptionist to the desk, to the manager in the back, to the doctor in the front, to the emergency room doctors. If you ain't got compassion, you need to find another job. Maybe you need to be a gardener. I know that your light is on, but I ain't finished yet, bro. I know your little light's on, but let me finish what I'm saying. Give me another minute, because somebody else said they had 5 more minutes. Just give me just a little bit longer to say what I got to say. Now, I have been kicked to the curb when it comes to mental health. Before I had a good doctor with compassion, before I had a good therapist that had compassion, I've been in and out the emergency room. I had been misdiagnosed. I remember I went to the emergency room one time. I had depression. They said I had a whiplash in my neck, but I had a broke disc. They had to go in my neck and operate on me for 6 hours. You go to the one emergency room, you go to another. They look at you and say, "Oh, you're back? What can we do for you?" They really make you feel kind of rotten. And it ain't right. But all I'm saying is this: if you're a doctor, a receptionist, a nurse, the main thing you need to have in this business is compassion. If you ain't got it, if you don't have it, find yourself another job. Find yourself something else to do. All you're doing is bringing the ones that need help. So I'm gonna end this by saying, there's so many things I want to jump on, but I ain't got but a few minutes. But I wrote a lot of stuff down on a piece of paper, but I kind of threw it to the side. Max is telling me what to say, which I appreciate, but I just want to get some things off my chest. If you haven't lived it, if you haven't had the problems, pray for those, help those that do. Help those that do. I can't tell you no more and no less, but if you got a job in the mental health system, please be compassionate. Thank you.
We are so blessed by your courage, Darnell, and your courage, Megan, to be here today and share with us your paths, your experiences. They're inspiring, and we appreciate it. Thank you so much. It is now my distinct honor to introduce to you Dave Richard. And it's a wonderful thing because I first met Dave when I first came to the General Assembly when he was had led the ARC of North Carolina, where he had been for 24 years before he came to the Department of Health and Human Services. I will tell you about Richard. There's never been a time when, Dave, there's never been a time when I've called and asked for something, asked for questions, asked for backup, asked for information, that he wasn't right there with it and with more than I was asking for. He's now the North Carolina Deputy Secretary for the Division of Medical Assistance. We call it DMA. He leads North Carolina Health Programs for the state's Department of Health and Human Services. His vision is to ensure a sustainable, person-centered, and innovative Medicaid program for the more than 2 million residents using the system. He is committed, and I have firsthand seen this commitment, he is committed to the fundamental goal of improving the health and well-being of all North Carolinians. And as I said, whenever I've asked him questions, whenever I've needed help with an issue, and let me tell you, the things he works on are very complex, he is always willing and able to be right there to help explain matters to me. So thank you so much, Dave, and we look forward to hearing your remarks.
Thanks, Senator Barringer, for nice, and congratulations, Senator Barringer and Senator Tucker. It was a brilliant choice for the award and two really incredible advocates for people. I'm not sure what I did wrong to deserve this, so I get to follow not only my boss, who started out and told me, make sure you tell about the details on what we talked about. So she explains it better than anybody I know. She's terrific at it. Senator Tucker and Senator Barringer getting the awards, and then the real heroes, right? Folks that have lived experience and understand what's actually happening here. And so I'm not sure how much I can add. I'm going to try to give you context about what we're trying to achieve, so that we understand when we think about the issues that Megan and Darnell brought up, how we believe we should try to address that. But let me first start out by saying that we know, and I say this clearly, we know that there is absolutely no chance of getting this right, and unless we listen to the people that experience mental health needs, substance use needs, and for the broader system, those that have developmental disabilities and traumatic brain injury. If we don't listen to people with lived experience, we will just live. You can't recover if you don't have transportation to get to the services that you need. And surely if your life is such that you don't have access to food and you don't have access to the other things that people need, then you're not going to live a life in recovery and you're not going to be successful. So we need to make sure we pay attention to that, and that's part of our plan and where we should go. And I'll say this, and we say it in so many different words, we hear case management, but the real issue is that we have to have community-based care management for people. Now, our LME-MCOs do a great job at care coordination, but the reality, our system needs folks on the ground to make sure that we can navigate the difficulties that we have. And those care managers, on the shift integrated care now, have to know about not just the specialty services, but have to understand our entire system, which includes our medical system. I love the work that CCNC has done in trying to work across this effort, but when you're treating somebody just about medical issues and you got a separate care coordinator that's worried about the specialty service side of it, and they're not together, then we're never going to treat the whole person. And here's why we believe that we have to have the system transformed. Representative Insko knows more about how this mental health system was designed and supported and the work that she did than anybody in the room. She helped design this thing along when Senator Tucker came along and others that were doing that work. And he designed a system based upon what was best known at the time. In doing managed care, I've admitted to Senator Tucker publicly, I'll do it again, doing managed care for behavioral health, Indian substance abuse, I opposed vigorously. I was wrong when I was with the ARC. The managed care system done correctly can absolutely make a difference in the lives of people. And there are a lot of good things that have happened. But we designed without one big component inside of it, not because people wouldn't have thought of it, it wasn't where the field was at the time. If we don't think about whole person care, we don't think about how to treat an individual and support an individual with all the tools under the one management agency that's got responsibility for it, we will always fall short. Now, you heard from people about what happens there. You'll hear from folks from Wakebrook a little bit about the work that they're doing, and frankly, the biggest barrier for their work to continue is our system that isn't designed to support the work that they're doing. We have to change that. And the way to change that is to design a system that says, we will treat the whole person and we will organize it at the plan level so that we can create and can support the clinical level in real integrated care. Because if we don't do it that way, it will not happen. Let me tell you a couple of quick stories and just about why I think it makes sense. You'll hear about Wakebrook, so I won't go there. There's a great primary care pediatrician practice in the Sand Hills area. Sand Hills area program has has worked hard to help support that practice. It's I forget the name of it now, I'm blanking on it, but it's local pediatrics, I think it's called San Diego Pediatrics. And they have brought in psychiatrists to their practice. So they've got their docs there, they've got psychiatrists and other health professionals and mental health professionals there, because what they've seen and what they believe and what they know is that when a child comes in who needs mental health support, if you can't get access to it right then, the odds of that support happening delay. But if you can get access immediately, not only do you help the child, you help the family. Because this is about families, right? It's about everybody in the family. Well, they fought hard. And what they fought hard with Sandhills is to get grant money from Sandhills so they could do this work. So it's a workaround. Now, what a silly workaround. The right thing to do, if our payment structure and our payment system were designed to support integrated care, it wouldn't be a workaround. And an incredible doctor like Dr. Diazio, who has fought the system to make this happen, wouldn't have to be the fighter. It would be the norm. And that's what we want across the state. We want the norm. So we want people to have the opportunity to take advantage of something like Sandhills Pediatrics, and moms and dads go there, to take advantage of Wakebrook in a normal system, one that rewards and creates the right incentives for practitioners, for communities to really integrate their services. If we don't, we'll continue to do things we've been doing. So here's what I believe. I don't believe that if we do the Taylor plan the way we described it, guarantees that every practice across the state, that every clinician, that every community will have integrated care. I don't believe that, because it's hard work. People have to continue to do that effort. People have to think about different ways to do it. But I can guarantee you this, is that if we don't change the system, if we leave it as it is today, siloed and segregated, there will be no comprehensive integration of physical health, behavioral health services, and really social services across the state. Because it's just too hard. We shouldn't require workarounds to make it happen. We ought to make the workaround the system. And that's what our goal is today. So let me just tell you quickly what it says so you understand, is that what we've proposed to the General Assembly, and we've had great support of people trying to figure this out, is that for people who have mild mental health and substance use needs, they ought to be able to get their supports and services from a regular standard plan as we go to managed care. Now, I had heart disease a long time ago, and after I had heart disease, I went to counseling because you're not supposed to have heart disease when you're 30 and have heart attacks when you do that. When I went to counseling, I didn't have to go to a separate system to get counseling or get a separate payer to do that. My insurance company paid for the psychiatrist I went to do the counseling and the support in there. As they paid for my cardiologist, as they paid for my doctor. And he coordinated that care because it was all under one payer. That's the right way to do it, right? But we know, and this is a North Carolina solution, we know the rest of the country is looking at integrated behavioral health, and how most Medicaid programs are doing that is by large commercial plans taking on a responsibility for everyone in the state and doing it that way. But we've built a system that actually has a lot of good things in it. We've heard about those things here, the things that happen in communities, the good stories that happen about how our LME-MCO system is integrated with our DSSs, how people work together, collaborate, make sure things happen, how our providers are part of that community, how we've developed this over years, and it's been an evolution, not a revolution to make it work. We want to continue using the LME-MCO system in order to facilitate integrated care. So our proposal has been, let's make our LME-MCO system, the folks that understand behavioral health, understand developmental disability and substance use at the core, let's make them work together with the health plans that are coming into North Carolina who understand how to manage physical health and integrate that at the plan level. Not two separate systems. Require the LME-MCO to own a contract and have a partnership with the health plan. So that as they're managing the whole person, that we've got the expertise that has been built up in North Carolina around LME-MCOs and the expertise that is built up across the country on how to manage Medicaid for physical health together. And what we believe is that over time, that system will not only improve what we're doing here in North Carolina, it'll be a model for the rest of the country. The word tailored plan was picked specifically because it is about tailoring the services for those people that have significant mental health, developmental disability, and substance use needs. Now, we have a little ways to go. The General Assembly is working hard to find a solution. They were very close back in a special session. What we're hoping is in a short session, when they begin early on, they'll come together and they will all agree on a solution going forward. And frankly, we are committed to working with House and Senate members, knowing that there are some minor differences, but let's get something done so that we can move on. Let's get something done. Here's the part that I believe is foremost, is that without a clear path forward, without knowing what happens in 4 years after we go live with the rest of managed care, without knowing what happens, we destabilize a system that's already fragile and one that needs to continue to improve. If we know the direction, if we can come together and understand that integrated care, how we're describing it today, how we'll all work together, if we understand that that will work, and that's the best solution for North Carolina, we declare it, we get it finished in this short session, all of us together can work to make that the best system of North Carolina can have. It's the way we've always done it. Again, we argued a lot about the LME MCO system, but when it was put on the ground, we all came down together to work to make sure we got it right. Now, there are things can be improved, so let's improve that part that is important now, which we know is best practice, integrated care, and the best way to do it at the community level is for making sure the plans work. So I believe, because I'm an optimist at heart, I believe that we will get that right in the short session. That'll happen quickly, and that we'll all spend the next year working together to make sure that we stand it up. It is the best that North Carolina can do, and I am confident it will be the best that the country looks toward for the future of behavioral health, developmental disabilities, and substance use across this nation. I have to say the same thing with everybody else is what an incredible group of folks. I want to thank Jenny and the rest of the chairs for all the incredible work to bring people together, and the spirit of partnership that exists in this room that you can actually feel when you walk in, right? You can feel that. What a great day, and what a great, wonderful spring day for North Carolina. And I think when we leave here today, I hope we're all inspired to get back to work, to make sure we get this right, and that we do the best for people of North Carolina. Our citizens deserve that. And we look forward to working with all of you to achieve that effort. Thank you.
See, I was right. He really is good at what he does, and we're so fortunate to have Dave Richards. It is now my honor and privilege to bring forward Dr. Jessica Waters Davis and Dr. Brian Scheitman. And let me tell you a little bit about these two individuals. Jessica, Dr. Waters Davis, is a family physician who directs clinic operations at UNC Wakebrook Primary Care. During her residency training with UNC Family Medicine, Dr. Waters Davis participated in the underserved track with an additional concentration in behavioral health, which included an opportunity for her to work with community-based behavioral health providers and provide a full spectrum of family medicine services. She maintains a strong commitment to caring for patients with mental illness, implementing the integrated healthcare model to treatment. Dr. Scheitman has spent the majority of his career working with the severely mentally ill. He currently serves as the medical director at the UNC Wakebrook campus for community behavioral health in Raleigh and is a professor at the UNC Department of Psychiatry. Additionally, he is a consulting psychiatrist at the NC Central Prison. Prior to these roles, he was the medical director at the UNC Center for Excellence in Community Mental Health and has also served as the clinical director at Dorothea Dix State Psychiatric Hospital for 5 years. Please help me welcome these two, and I'm sure they're going to share some really good information with us and their experiences.
Thank you. It's a pleasure for both of us to be here today to talk about some of the work that we're doing at UNC Wakebrook. We're going to talk about primary care, physical health care for people with serious mental illness. The reality, all mental illness is serious, but we call serious mental illness the subgroup of disorders like schizophrenia and bipolar and depressions that really haven't fully recovered. So these people all struggle with things that we oftentimes kind of take for granted, like work and social relations. We're kind of nerdy, so we're going to use slides a little bit, if that's okay. So there's like 3 objectives we have. One, we're going to review the current challenges of providing physical health care to those with mental illness. And when I get through with that, we're all going to be extremely depressed because it's actually really sad. I mean, we're doing a terrible job. Next, we'll try to uplift you from the depression and talk about some of the work that we're doing at Wakebrook. And then last is the ask, what do we need to make this model work? And I've been thinking about it, and part of me thinks that we should talk about that even up front. So we have a model that can work, and people with serious mental illness can get the same care as people who don't have serious mental illness. But the barrier really is one of funding. So I've been doing this for a long time, gone to god-awful numbers of meeting about integrated care, but there is the problem of how do you pay for it? And when we looked at the numbers, it's really some of the back end, emergency room, inpatient stuff has to be brought to the front end. And we looked, it was about 3% of the total cost of caring for these people. So 3%, it was about $40 per person per month. So of the total cost, only 3%, if it was brought from the back to the front, would really improve care dramatically. But if we don't do that, we're going to tell you what we did, we're going to discuss it, and then it's going to be like the last 20 years and nothing's going to happen because it's a funding issue. But the knowledge really is there, and we can make great improvements if we get some help with this. Okay? So we have no conflicts of interest. I was actually listening to the experiences, and now that something's happened in healthcare that a lot of people don't really trust the providers anymore. It's kind of interesting, and I have some suspicions possibly why that is, but we have no conflict of interest. We're not getting any money from anybody for this. So in all healthcare now, there's something called a quadruple aim, and that's what you strive for. It's pretty straightforward and makes a lot of sense. You want good clinical outcomes. You want the patients to actually be happy with the care. And when you talk about the serious mentally ill population, the reality is most of them don't even receive physical health care. They're not happy with it. You want it to be cost effective. Right now, I can tell you it's not cost effective. We're spending a lot of money for bad outcomes. And the last one, which I used to think was just a bunch of BS, provider satisfaction. Like, you're getting paid, go to work, what's the big deal? But the reality is it actually is. And in primary care especially, healthcare has dramatically changed. So people see, like, the average provider is going to see, like, every 5 minutes a new person comes in. And that is really, really turning a lot of people off. They leave their jobs. So it's really hard if the providers also aren't satisfied to get these good clinical outcomes, patient satisfaction, and to be cost effective. This is a bigger problem than we think. And when it comes to serious mental illness, a lot of primary care people really don't want to work with them. Not that they have anything against serious mental illness, but it just really interferes with the workflow. Like, everything is a workflow issue. So if you get someone who has 5 problems and has all these other things, it's not like a 5-minute appointment. You just can't do it. So it's really kind of changed the way we do things. And I wonder if people are a little more skeptical of providers because the system isn't really set up to support them anymore. So this is really pretty striking. This is, many of you probably have heard it, but these are bar graphs of a lifespan of someone with a serious mental illness. So on the left is if you have no mental disorder, your lifespan is about 77 on average. On the right, if you have a mental disorder in the public sectors, which was most of where people with serious mental illness lie. So the difference is 25 years, which is enormous, with having a serious mental illness and not having a serious mental illness. And most of that really, when you think, well, serious mental illness, it's because of maybe they committed suicide or something like that, but it's really 85% of that can be attributed to their physical illness. So most of this is not because of the serious mental illness, because of the physical problems associated with the physical illness. So in putting it in reality, in sort of here and now terms, a guy like me, I don't have a serious mental illness, but if I did, the likelihood is I would not be up here talking to you, not because of the serious mental illness, but because I would be dead. And I would have been probably on average dead many years ago. So that's, it's really like you get kind of, shafted in life by having a serious mental illness, and then you lose 25 years of your life to boot. And that doesn't necessarily have to happen. So not only for the privilege of dying 25 years earlier, we're actually paying a lot of money for it. So again, if you look at the bar graphs, the one on the left is, on the right, is probably more pertinent to what we do with Medicaid. But if you have any mental disorder, it's the red, and no mental disorder, it's the beige color. So the difference is about $900 per member per month, more costly for all care for people with a serious mental illness versus not a serious mental illness. So to go back to the money issue again, just harping on that, it's about $40 increase the amount of primary care per month, and the difference is about $900 per month. So it's it's a costly difference of having a serious mental illness. So I don't think you could make a strong argument really getting our money's worth. So why some of this disparity? A little bit I mentioned, people with serious mental illness are more likely to have multiple chronic medical conditions. In addition, what we've heard is they also have all this other stuff. They're homeless, they don't have enough food, it's hard for them to find jobs. Many nowadays have been incarcerated, which makes it even worse. They have a lack of social support system. Transportation is a problem. Many have been traumatized. We hear all this stuff in the news about mentally ill people being aggressive. It's mostly the reality. They're much more likely to have been traumatized, and substance abuse problems and tobacco are rampant. So again, putting it into a provider perspective, if you've got to deal with all this in about 5 or 10 minutes, it doesn't work well. And that's the model we're going to talk about tries to change that some. So our current models, what do we do now? The truth is they really don't work. For serious mental illness, there's actually not bad models out there. We don't have them implemented for the not serious mental ill, for anxiety and depression things. But for serious mental ill, oftentimes we put a behavioral health provider in a primary care clinic. We can kind of check the box, we call it integrated care, but it's really not working. The pace is way too fast in primary care. The number of people who have a mental illness of any sort is about 25% with substance abuse. It's just not working. And also to put a medical provider in a behavioral health clinic, usually they work a couple of half days a week, but that's really not primary care, like full scope primary care that we get, like preventative care. Are you up to date with your colonoscopy? That doesn't happen at all. It's more just like, how much you weigh, go get your blood checked for diabetes. Nobody checks to see if people follow up. It's really just not working. It's just with kind of throwing the money away, quite frankly. So on that note, I'm going to turn it over to my colleague, Dr. Waters, who's a primary care physician at Wakebrook, who's helped set up this model that we think actually works, and we have actual data to show that it works. It's not just talk. So I'll turn it over.
Sure. So, hi, I'm Jessica Waters. Thanks, Dr. Scheitman. So I have the privilege of sharing what we think is a model that actually does work to care for patients with serious mental illness. So this is the UNC Wakebrook campus. Wakebrook Primary Care is located in the FAR building there. We opened our doors in 2014, and we share the campus with several psychiatric inpatient, crisis assessment, and detox units. So we are co-located with psychiatric providers. The model that we'd like to talk about today, we've given the name Enhanced Primary Care for patients with serious mental illness. So I'm going to spend some time on this slide because this is the crux of what we do. In the blue box on the left, those are the components of the patient-centered medical home. So this is the current standard of care for providing effective primary care. And actually, it's increasingly required by payers for reimbursement. We are at Wakebrook Primary Care a level 3 certified PCMH, which is the highest level you can achieve. And what that means is we have to demonstrate that we meet all 5 of these qualities. And I'd like to highlight 2 of them in particular. The first is that the care has to be patient-centered. So we talk about caring for whole person. Patient-centered, really meeting the patient where they are and answering to their needs. And continuous. Continuity between the patient and the provider means that you have sort of a personal primary care provider who gets to know you over time. And because of that relationship that you build, can provide more personalized, more effective care. The second part that I think is really important that we are able to provide at Wake Fork Primary Care is comprehensiveness. So I think this is where Dr. Schechtman was talking about, a single part-time primary care provider in a behavioral health clinic may not have the resources to do this. We are able to provide a full scope of primary care services. Ideally, a primary care practice would be able to meet about 80 to 90% of a patient's health care needs within the walls of their clinic. So that includes preventative care like pap smears, cholesterol screening, etc. It includes acute care, so like you sprain an ankle or have bronchitis, you can call and get a visit that day. End of life planning and coordination of care. So really being able to offer all of those within our clinic walls. So in addition to the patient-centered medical home components, we argue that there are 3 additional components needed to care for patients with serious mental illness effectively. The first is that it takes more time to provide good care to someone with serious mental illness. Many of our patients may have a psychotic disorder. They may have some element of paranoia. Often they've had negative experiences with the healthcare system in the past, or they may have experienced trauma. And so it just takes more time to build a relationship with that person, to gain their trust, to counsel on treatment options. And sometimes it takes more time to gather the information that you need to make to make an informed treatment decision. You may need to call a family member or a legal guardian or their psychiatric provider. So in order to achieve that additional care, additional time, we schedule our patients for 30 to 40-minute visits, an hour for new patients, 30 to 40-minute visits for a return patient. Whereas in a regular, traditional primary care practice, you're getting 10 to 15 minutes with a patient, 20 at best. And I practiced under that model as well, and I can tell you that it's just inadequate to care for a patient with serious mental illness. We also see a target of fewer patients within our clinic. Because we're taking longer visits, our target panel size is about half what an average primary care provider would have for panel size. So the second component is specialized training for the healthcare team. We have in our clinic both physical and behavioral health providers. And not only do all of our providers and staff have an interest in caring for patients with mental illness, they have upfront training and then repeated annual trainings in topics such as crisis de-escalation. They are trained to provide additional counseling around even routine procedures like a blood draw, and really to take the time that's necessary to meet the patient where they are. The third component is proactive and planned communication between the primary care team and the patient's psychiatric providers. So this is where we do our integrated care. We have protected time. The providers and staff have protected time each month to meet with each of our major psychiatric partners, so our referral sources, including the ACT teams, these sort of community treatment teams that provide a lot of community-based behavioral health services to our patients. We are also in frequent contact with the behavioral health team in between those planned meetings to discuss treatment changes, monitoring, any perceived, decompensation in patients' mental health. If I see that I think they're not doing well, I will call their psychiatrist. Patients give us permission to have this kind of open communication, and I think it's really essential. In addition, we have the benefit of being located on a campus that's primarily a psychiatric treatment facility. So if a patient is in crisis, we can walk them to the crisis unit ourselves. So I think that those three components are really not only additional, but they're required to provide good primary care to patients with serious mental illness. So here's a snapshot of whom we care for. Our current panel size is about 585 patients and growing, up to our goal of 750 to 1,000. We think we'll meet that in probably the next year or so. And you can see that in addition to having mental illness, such as bipolar disorder, schizophrenia, or severe depression, our patients experience a high level of chronic disease and physical health burden as well, including these chronic illnesses that carry a high rate of complication and mortality. You can see the percent of our patients that smoke or use tobacco products is 65%, which is significantly above the national or even state average. I think the state average is about 18%. In terms of insurance, about 75% of our patients are publicly insured, 22% are uninsured, and then 8% fall into the category of other, which may be private insurance or sort of an unclear insurance status at the time of the visit. This is our fantastic staff at Wakebrook Primary Care. In order to care for our 750 patients, we employ the equivalent about of one full-time primary care provider. It's actually a split position between family medicine physicians and some nurse practitioners, PAs, who work with us, but the equivalent of one FTE. We have a nurse and a medical assistant, again, with interest in and training in working with patients with mental illness. We have an office manager who works our front desk as well and knows every single patient who comes in the door. And then we have what we call our enhanced primary care team. So this consists of 2 licensed clinical social workers who provide a wealth of services, including health behavior education, wellness classes, individual client support, referral coordination, intensive case management, and they often collaborate with a behavioral health care coordinator too if the patient has one. They also work closely with our peer support specialists who are people who identify as having a mental illness, and they provide a wide variety of services: individual client support, wellness groups, outreach, and even home visits. Sometimes they'll even go to someone's home, take them to the grocery store, help them learn how to buy food, and then cook a healthy meal at home. So really extensive health behavior services that we're able to offer. And as a primary care provider, I've never worked in a place that was able to offer what are actually evidence-based interventions for health behavior, including the smoking cessation and the nutrition counseling and the wellness groups for these types of health behavior problems. Okay, so this slide we are quite proud of. So this shows the percentage of patients at Wakebrook Primary Care who are up to date on certain recommended and evidence-based preventive health measures, such as breast cancer screening, depression screening, aspirin use for patients with diabetes, vaccinations, etc. So on the left, in spring 2016, which was not long after our clinic opened, you can see a lot of red, basically. We are not meeting these measures for our patients. And this is when we were gathering a lot of new patients, and we think actually this probably represents the state of preventive care for patients with serious mental illness in the community in general. They are not getting the preventive screenings that someone in a middle-class suburban private practice would be getting, and that they need really to improve their health outcomes. So as you move to the right, forward in time to fall 2017, we are thrilled that actually now a lot of that red has turned to yellow, which has turned to green, and we are now meeting the target goals for a lot of these measures. And even in measures where we're not meeting the goals, colorectal cancer screening and cervical cancer screening, for a variety of reasons, we've actually still doubled our cervical cancer screening rate and increased by 50% our colorectal cancer screening rate. So we are still making progress. I think it's important to note these goals are set by the UNC Primary Care Improvement Collaborative, which is based on national benchmarks for primary care. And it's comparing the rate of preventive services to all primary care practices. So not just practices that serve patients with serious mental illness. So the fact that we've been able to bring these numbers up to match other primary care practices is something we're really proud of. And ultimately, we believe that this is going to translate into more positive health outcomes for our patients as they receive the screenings and the care that they should be getting. We're happy to say that our patients are overall pleased with the care they get at Wakebrook Primary Care. I think I can speak anecdotally to this, to the fact that the way that our staff and providers work with patients really does help to engage them and encourage them to come back. I have a patient, for instance, who is in his 40s. He has bipolar disorder and he is homeless. And because of his illness and because of the psychosocial factors in his life, it's really difficult for him to organize his health care and make it to scheduled appointments. He often, in fact, I would say he rarely comes to his scheduled appointments, but he often shows up on another day requesting care or with a question. And my experience is that in a regular primary care practice, a traditional one, he would probably be turned away at the front desk because no appointments were available and come back on another day. Or perhaps dismissed from the practice for the number of no-shows that he had had. But at our practice, the staff knows him and they know these barriers that he experiences. And when he comes to our clinic, they go out proactively in person and speak with him about his needs, try to triage any acute concerns, perhaps engage a provider or get him on the schedule if possible, and then reschedule him at a time that works for him. So as a result, he keeps coming back. I think it's the first time he's ever really had an established primary care provider. So I know we're short on time, so I'm going to go a little more quickly, but these are the components that we think really makes this model work. We've already talked about the building blocks of effective primary care, full scope, open access, and continuity between the patient and the provider. The way that we achieve integration with the psychiatric and behavioral health teams through frequent communication, face-to-face meetings, and co-location. And then really this allows us to address the social determinants of health that we've been talking about that are such drivers of healthcare outcomes. And we believe this model is generalizable beyond our walls to other communities and other clinics. And we're hoping to build a network of providers doing similar work who can share best practices and continue to grow the model. So here's our ask. What is required to care for these patients? For our 750 patients, our current annual budget is $750,000, including operating costs and salaries, so all costs, which comes out to about $80 per member or per patient per month. Or if you offset it with the fee-for-service reimbursement that we get, that would be about $40 additional per member per month. And just to compare that to the numbers that Dr. Scheitman shared, where the current estimates of the cost of total health care for patients with mental illness is $1,300 a month, we really would take such a small fraction of that to provide this kind of effective primary care. And our goal would be, as you can see, it's $1,000 or more for an emergency room visit. Our goal would be, as we invest in effective primary care and enhanced primary care, we could start to divert people from the higher cost services such as emergency rooms, urgent care, and hospitalizations to get care in our clinic, and additionally, hopefully improve their health outcomes and reduce disease burden, which would further reduce costs. So I think the upfront investment would equal significant savings in the long run. So I'm going to turn it back over to Dr. Scheitman for some closing words.
Thank you all for allowing us to talk about this. We appreciate it. We got a grant from the federal government to help us for like the first 2.5 years, and we have about another 1.5 years to go. And UNC Healthcare has been very generous. Alliance Behavioral Health has given us some support. I think Wake County sees the benefit of this. But I think to really make this go, the funding is going to have to change. But it's not really that much money. You think, we've got to fix this once and for all. I think this can do it. So thank you all very much.
All right, ladies and gentlemen, you holding up? All right. I want to give special congratulations to the Durham delegation of the General Assembly, because Durham County is the only delegation that has its entire group of elected representatives and senators here. Good job. And I want to welcome Mike Woodard, the senator for Durham, who represents Person and Caswell counties as well, to the stage for our next recognition.
Good morning. When I walked in this morning, Greg asked me, I can't wait to see what you're going to say about Mickey Mishaw, because I think he recognized that to speak about this great and long-serving leader would be a daunting task. And it has been the last couple of days to think about what I would say about Representative Mashal. But when I sat down to do this Thursday night, I thought, WWMD, what would Mickey do? My legislative colleagues know this, and I suspect most of you do as well, that Representative Mashal is quite a student of great literature. He studied all the great works, and occasionally on the floor of the General Assembly, in committee meetings, and in speeches he gives, he'll regale us with some piece of great literature. Nobody quotes Dante quite like Mickey Mashal. So I went to my library Thursday night, my bookshelf, and tried to be inspired, and I found the book that I think helps me capture Mickey Mashal. In 1841, Ralph Waldo Emerson wrote one of his best-known essays, Self-Reliance. Now, if you hang with me a second, I think you'll see, I don't think Mickey knew Emerson. They might have been contemporaries, but I do think, but Emerson in some way, I think, captures the essence of Mickey. This essay contains the most thorough statement of one of Emerson's recurrent themes, the need for each individual to avoid conformity and false consistency and follow their own instincts and ideas. Emerson objects to the individuals conforming to either customs of the past or the cries of the multitude when those forces are contrary to their own judgment. He writes, "What I must do is all that concerns me, not what people think." That sounds like Mickey. Emerson goes on to say that the world always misunderstands the great individual as they misunderstood heroes of the past, such as Socrates, Copernicus, Galileo, Newton. But the important thing, says Emerson, is to be true to one's self, not to violate one's own nature. To be true to one's nature is to be great, to avoid what Emerson calls the smooth mediocrity and squalid contentment of the times. That sounds like Mickey. Emerson issues a call for all of us to be great in this way, leading other people instead of following. The great person, Emerson suggests, is a creator, not a user, a leader instead of a follower. And he writes, "Every true man is a cause, a country, and an age, and requires infinite spaces and numbers and time fully to accomplish his design. And posterity seems to follow his steps as a train of clients. A man Caesar is born, and for ages after, we have a Roman Empire. Christ is born, and millions of minds grow and cleave to his genius. An institution is the lengthened shadow of one man. All history revolves itself very easily into the biography of a few stout and earnest persons." Henry McKinley Mashal Jr. is one of those stout and earnest persons. And when Representative Mashal walks away from the General Assembly in December, after 40 years of service, his lengthened shadow will continue to cast itself across that iconic building on Jones Street. It was at the urging of his friend Martin Luther King Jr. that Representative Mashal entered politics after graduating from law school and establishing his legal and business career. After 2 terms in the General Assembly, Representative Mashal was appointed by President Carter as the first African American to serve as a U.S. attorney in the South since Reconstruction. He returned to the General Assembly in the early 1980s, where he became a leading advocate for voting rights and the expansion of the franchise. Education, which led his alma mater, North Carolina Central University, to name its School of Education in his honor. The funding and expansion of our state's HBCUs. The election of African American judges. And, for our purposes today, accessible health care, particularly mental health, especially for underserved communities and populations. As Senior Budget Chairman for the House, Representative Mashal crafted forward-thinking budgets and maneuvered them through the legislative process. Additionally, Representative Mishaw has been a mentor to dozens of younger legislators and elected officials in Durham, in North Carolina, and across the country. Representative Mishaw, it is with deep gratitude this morning that we proudly present to you our appreciation of distinguished service for your untiring efforts in working to improve the lives and outcomes for vulnerable populations in our state. Congratulations.
You don't call a politician and lawyer before a microphone. Greg, thanks so much. But Mike, you outdid yourself. When he got through, I was ready to say, let's just lower the coffin and go home. I'll have to have my wife remember that when you get ready to do that. But I certainly appreciate the honor that you've given me today. I apologize for being late, but I had to attend the services of a longtime friend of ours in Durham. But I was great. There was one slide that came up that caused me to pause, and that was the one that showed the life expectancy, particularly of those who didn't suffer any type of mental impairment. And the reason that I passed that age limit there, and it cleared my mind, because for the time that I served in the General Assembly and what I had to go through, I always thought I had a mental impairment. But now I'm glad to see I passed that by that life expectancy on that. But here again, I learned in the General Assembly from one of the main persons who put our whole mental program before the state and tried to make it grow. Many of you will remember Kenneth Royal. Ken was really a great forefront person for mental problems that this state faced, and pushed forward many of the great programs, and we relish the legacy that he left us. One of the reasons I got to be senior chair of appropriations was because Ken taught me two things. He taught me how to count money and where I could find money, and he taught me how to make sure that my commitment to those who were underserved would always be served. That was the mantra that I got not only from Ken Royal, I got from my friend Martin Luther King Jr., and I leave you with Dante. And this has always been something that I've believed in. The hardest places in hell are reserved for those who take a position of neutrality in the face of a moral crisis.
Y'all, that's a living legend right there. Representative Mickey Mishaw. I'd like to invite the legislators who are going to serve on our panel to come up and join me on the stage. This is going to be my favorite part of the morning because I actually don't have to sit up here and answer y'all's questions. This is an extremely well-educated audience, and one that usually at this breakfast has some questions that force legislators to do some deep thinking and make some strong commitments to important issues. I'm sure that you're going to be up for that this morning as well. The panel will be moderated by Rose Hoban, the founder and editor of North Carolina Health News. Rose is a regular, everyday participant at the General Assembly, covering health news in a way that no other media organization in the state does.
That's right.
If you think that you're paying attention to what's going on with behavioral health, physical health, anything related to health, if you think you're paying attention to it because it's on a big TV station or a newspaper that comes out of a major metropolitan area, you are not getting all the news unless you're paying attention to what Rose does with the North Carolina Health News. It's really wonderful. And on stage, your questions will be directed to Representative Pat Hurley of Randolph County, Representative Marion Black, Durham County, my fellow social worker, Representative Carla Cunningham from Mecklenburg County, Senator Tommy Tucker, who you heard from earlier today from Union County, and Senator Floyd McKissick, also from Durham County, representing Granville County as well. And I think we're ready to go.
Just a couple of housekeeping things. So everyone has some cards on their table. If you would like to submit a question during this process, just write it on that card, hold the card up, and someone will come to you and take that card. And we'll have people throughout the room to come do that, and we'll get those questions to Rose. On another note, I hope everyone got their beautiful cups that we have this year. If you're a sponsor, make sure you get your bag before you leave. So have a cup, they're beautiful. Also, on our program, on the back page, we've got a QR code to give us feedback about how we did this year. Please take the time to give us some thoughtful comments about that. Thank you.
Thank you very much, Jenny. And folks, you know, I've done this for the past couple of years, so I'll stand out here and they'll give me cards when you have questions. And I'll say that the questions I've got here are all questions that have been submitted by people here. And let me tell you, they are amazing questions. Representative Myers wasn't kidding that this is a very well-educated audience. I have added some little notes on my own, but for the most part, these are questions that folks here have asked. And so we'll jump right in. And we have a somewhat shortened time because we ran over, so I'm going to ask for folks to be terse. So, and to the point. So the first thing is, do we know what the timeline is for LME-MCOs in the transformation of Medicaid? Do any of you sort of have a sense of that answer? Senator McKissick.
I think the most recent information that's been discussed would look as if they would continue operating, functioning, and providing mental health services for those who have those severe mental illnesses for somewhere in the 4 to 5 year range. Originally, about 3 to 4 years were discussed, but right now it's looking as if it'd be about a 5 year range after Medicaid managed care goes into effect, and then after then, they would still be able to compete for services, but it would be with against other providers.
Representative Cunningham was shaking her head a little bit, but.
Well, yeah, a little bit. It's supposed to be in place, the initial by 2019, and then it would be a phase-in for individuals with a serious mental illness could take up to 3 to 4 years. So it's a phase-in for that special population, and I think that's what Senator McKissick was saying. This is a phase-in for that certain population.
So in short, we're seeing that there's going to be changes, but, and I'm looking over here at Dave Richard, and looking for a nod or maybe a shake of the head, which is that it's going to be a short phase, and there's not going to be big transformation in the immediate future, but in a couple years down the road, we're going to start seeing things, right? But it's fair.
Yeah, I think what you're talking about, if you look at really when we're doing the transformation, that's July of 19. But moving that point forward, that's merely at a 4 or 5 year window for the LME-MCOs to continue providing services for the ones with the most severe disabilities. The whole part-time care goes for the rest of the population.
And one of the questions, and I want to make sure that this gets asked, although this might actually be a question for the department, which is, how will this new model affect private insurance patients who have mental health needs? I mean, this is for Medicaid, right? So, doesn't affect them. Okay, it's just.
It would not affect them whatsoever. Right. No impact.
I just wanted to get that out there because that was one of the questions that was asked. So in Medicaid transformation, we're moving away from a fee-for-service model to a value-based one. Who will decide what has quote-unquote value and what a service is worth? And What if providers are asked to produce outcomes that are not clinically sound, or if the payments are so low, but as we heard from the folks at Wakebrook, that the service cannot be provided? Thoughts? Anyone want to try? What is value? Do we know what the value is going to be?
I'm not certain how they're gonna do the measurement, but in the healthcare profession, when they're looking at value, they're looking at, are there improved outcomes? And so if we're moving from a fee to a value, I'm sure they're gonna start looking at evidence-based and start looking at if those assessments and if those outcomes are being improved. That way they would get paid not for fee for service, but if they are producing results and better outcomes.
Okay. Obviously, there's questions out there about how this actually is going to play out. So, will there be certain clinics that offer these integrated healthcare, or is this model expected to be used by every health clinic across the state? Again, this might be more of a departmental question. Senator McKissick.
Well, sure. It would basically those care providers would be involved. All care providers would be involved in integrated care. Those that are providing whole person care. Now, in terms of some of the kind of small providers today, they'd have to be contracting with the managed care companies to do so. But any of the managed care companies, you're looking at about 4 of them that would be in existence across the state, as well as any provider-led entities that would come into play, would be providing integrated care.
Anyone else want to jump in on that at all?
So back under the old agency system, area agency system,
It was really easy to figure out where to go for help. Under the LME system, it's been confusing and complicated to find services, and there's been constant change. How will individuals in the communities be educated about where to go to receive mental health services? It's still very confusing now.
let me say, for 36 years, I've been involved with the mental health system because of my son. And I don't care what system we have been up under to get services, it's been complex, it's been difficult. And I don't know how we're gonna figure that out and how the community really knows what to do and where to go to get those resources. Because even myself as a nurse, that was still difficult. That was not my specialty, but it was still difficult to navigate a system, and that's been 36 years. And it has not become any less difficult. Public service announcements for us locally, we don't see a lot of that on mental health. We see it on everything else, that maybe the stigma keeps it off of the radar of putting it out in the media. We have to improve in that and how to link up to those resources, and we just haven't gotten there yet. And I think we keep changing the system and changing the system, and that doesn't give the people that need to be involved in it an opportunity to learn what to do, where to go, who to call.
Well, as we talk about the whole person, it becomes very important to make sure that we have great primary care providers, and that each person who has a mental health illness, or each person has a primary care provider, and that's the starting place. And then that primary care provider becomes the person who can coordinate services for you. I understand, I'm in Durham County, so I understand that we have many more opportunities to receive services than maybe some people in our rural counties. But with telemedicine becoming big now, and I think it's going to be paid for, that's going to be a way to access services, I think, better. But I do think that primary care doctors, are they still here? Primary care physicians are the people, I believe, who should be at the table coordinating services for every single person who has a mental illness. And that our emergency rooms, and one of the speakers earlier was talking about his trouble in terms of accessing care through the emergency rooms. Well, I work at Duke Hospital, and we love to keep people out of the emergency room, first of all, because of the cost of going to the emergency room, but it's also not the best way to get your cost. So let's go back to having that primary care for doctor be the person who's going to coordinate services across the board for everything that you need.
Mm-hmm. There just is one question. Actually, we got several questions that were related to this. Do you think we'll ever return to a community mental health model? And why don't we go back to community mental health centers?
I'll take that one. I don't think we'll ever go back to the community health centers. If you'll recall, back in the last decade, 2007 and 8, we were running about $500 to $700 million deficit in mental health care. We moved to managed care because we had those deficits in the Medicaid budget. I think managed care is the way we'll end up going. I think the LME MCOs, like Senator McKissick and Representative Cunningham said, that they will be around 4 or 5 years. I can remember when Secretary Voss told the LME MCOs they'd be gone in 2 years. Some of you may have been around when you heard that. It's a heavy political lift because it is so much community involvement with LME MCOs, but I don't see us going back to community services. That was abused. That was when people would take a van and put 6 or 7 clients in the van and take them to a movie into the Golden Corral and charge the state $60 an hour for each one of those individuals. There was a lot of fraud going on with that in the state. We found that to be the case, and now we've got it capped where we've got some budget certainty with mental health. So I don't see community services coming back other than the community involvement through the LME MCO.
I've been in the General Assembly 12 years now, and my first year there, I got calls from many people with mental health problems, and I went to many meetings to learn. They didn't even have an 800 number to call. They were tearing it up, and I know Randolph County supposedly had an excellent communications and coordination and a wonderful mental health support there at that particular time. And ever since I've been in the General Assembly, it has changed over and over and over again. I don't know how the community has kept up with it that needs the services that they need. But I do hope and pray that we get the word out there correctly and these people know, and the homeless, I don't know, but somebody's got to take control and make sure that this is out there in the right way so that they will get the services they need. And of course, I think they're right, the primary doctors and the doctors for the mentally ill and everybody that works with them needs to be able to tell every one of them that comes in where they can get the services.
May I chime in? I guess I should reflect upon that since we have gone to the LME and the MCO system, that they have case coordination that oversees how the dollars are managed for those services, and they do thorough checkups. So they go in periodically and evaluate. So I do see that that is one component that has really significantly helped in the coordination of my son's care, and it saves dollars because it's coordinated.
That's great. That's actually pretty exciting to hear. And there was, just as an aside, you know, every year the organizers of this meeting, they fret, like my email is filled this week, like, I'm not sure we'll have enough questions. You know, that's never a problem here. This is group, as you've seen, I've gotten handed about 10 pieces of paper. There was this, related to that last comment you made, Representative Cunningham, how will the legislature ensure that valuable partnerships between MCOs and their consumers and family members represented today by CFACS will continue? Will this relationship continue to, for this relationship to continue, will this be required, you know, will you have to make statutory changes? I mean, would you be willing to make statutory changes in order to make sure that CFACS have a role?
Well, from what our management falls up under, well, we know that Cardinal in my area comes back to our county commissions, and there is a CPAC representation on that board currently now. And I think that that relationship will continue. We have to have the voices of consumers take part in what is going to happen within that, you know, environment for that care. So they need to definitely be involved, and I see that as a continuation.
Rose, I also go back to the comments of Dave Richards earlier. If we don't involve the consumers of the services, then we won't get it right.
I might simply add as well, I think consumers are an integral part of that feedback loop, and I'm absolutely certain that if there's a need for statutory change, that will occur. But within the existing structure, it's possible, working administratively with the agency, particularly with Dave Richards' commitment to doing so, which I've heard articulated publicly and privately, there will be that desire to receive that input to make sure the services are provided as effectively as possible.
I will say that, you know, in my email that I get from readers, that is one of the big concerns that I hear, is that there is a voice for CFAX. I think there'll be people holding you to all of it. Senator Tucker, you know, you're kind of going to get off the hook because there won't be people calling you and holding your feet to the fire.
I'd say that again, holding my feet to the fire, I'm used to that.
As statutes are changed and our MCOs either change or disappear, how will consumers and their families and advocates be able to provide feedback? Okay, so that's this. But because the system is going to a more privatized system, will those private companies be compelled to take our input?
Compelled to take what, I'm sorry, I can't.
Input from you know, CFAX and consumers and families. You know, we're going to have private companies who are administering care and managing care, you know, and then are those companies compelled to take input from families and consumers on how they're doing or what's needed?
Well, you know, I'll just try to address that. The LME MCOs will continue to exist even into the managed care model. They will be contracted to do that. People call on our office and talk about whole person care. A lot of the managed care companies that want to come in and bid on this want to do the physical side and not do the mental side. They say they can. Initially, when they came in to talk to us, they said they didn't want it. Now they see the big dollars that are there, now they're saying they are. But we've got the LME MCOs. I don't know about the rest of the legislators here, but my phone rang off the hook, as Pat alluded to early on in 2011, 12, 13. You know, the LME MCOs are doing something right. While they don't get it all right, we're not getting the calls we did from consumers yet until the single stream funding money runs out for the uninsured and they start showing up in the emergency rooms, which the LME MCOs are paying a great deal now for the uninsured. So my point being is the LME MCOs will be there, the input and availability, and some of the same people you dealt with will be there. No question about it. And then you'll have the PLEs, which is another layer rather than having to go all the way to the top to the large MCOs.
If you don't get the services you need, there's always a legislator to come, and there's oversight committees that we need to bring into their attention if they don't do what they're supposed to do. So as we're moving forward in terms of looking at all that we're doing around mental health, which is really important, and integrating mental health and physical health together because they go together, it's going to be very important to make sure that we're looking at the providers and that the private industry does not end up taking more of the money away from our providers, thus leaving us in harm's way. Because if the people who are delivering the services cannot be paid at the level that they need to be paid, they're going to walk and do something different, and we'll end up losing some valuable providers. So that's one of the things I've mentioned as we move forward down this path, making sure that the psychiatrists, the social workers, the counselors, psychologists, and whomever, case managers, deliver the service, that they're also being paid and not being skimmed off the top, leaving less money for the people who deliver the service.
And one thing I might add on that very note is that these managed care contracts are simply that. If for some reason these providers are not providing services in an effective way to consumers, then those contracts will be up for grabs. I mean, it's not likely that they're going to get renewed on the same terms. And likewise, under those contracts, these providers are, as I recall the data that I last saw, they're going to be required to spend about 85% of the money they get in on patient care and delivery. Only about 15% is reserved for kind of their management and administrative costs and fees. So there is assurances that the money is going toward consumers, and if those consumers aren't getting those services, if legislators are getting complaints, if the feedback loop that's established through HHS to receive that information suggests that there are deficiencies in delivery, those contracts will be up for grabs the next time.
Because that's just sort of dances around one of the elephants in the room, and which is sort of around my next question, is that we saw some outrageous expenditures by the former leadership at Cardinal. In a commercial MCO system, what kind of leverage will we have if there are spending abuses, and what will be put in place to prevent such things from happening in the future? And I saw this question, and I just did a quick lookup. Some of these are for-profit companies. Third quarter earnings for last year came out. Molina, which is a large MCO, $5 billion in third quarter. Aetna, $15 billion. WellCare, $4 billion. Centene, $11 billion. So I think folks have some legitimate concerns about, how are there going to be guardrails created in order to make sure that money is going toward care and not toward administration, etc.
I think that we addressed that when we took up the Cardinal initiative about what was happening with Cardinal. And Senator Tucker, myself, and some of the other legislators were very much involved in looking at those contracts that are done with the Department of Health and Human Services, because that's the contract that they have. But that contract still has to abide by what the state of North Carolina says it does. So we still have a level of oversight. And if we have to change statute to make things change, and I believe Tucker and myself, we've talked about it significantly enough to put some oversight and some accountability in place when they sign those contracts. And I believe that's where we are on making sure that the money is spent right. And I said earlier, now Cardinal is my provider. I make sure I keep in touch with Cardinal, but also they're sending in periodically to make sure that those outcomes and those services are being met. And you can believe me, if my son's services are somebody that called me, services not being met, I'm gonna get on the phone and find out why, or help them any way that I can. And I think all of us do that, but that accountability has to be in place. And I believe we began working on that last cycle. I'm sorry, but you could not get anyone as harder on Cardinal as myself and Senator Tucker, because we understand Cardinal, what was going on. But bad apples are everywhere. In every profession, you're gonna have somebody that's not doing what they're supposed to be doing, and that's why you have oversight, and that's why accountability is supposed to be there.
That's right.
Rose, just let me. Couple of comments. First of all, profit is not a bad word. I run a business and we have to have a profit. Some of those numbers that you recited are from other insurance companies and those kind of things. It's just not the MCO dollars that are there. For instance, United Healthcare already has 5,000 employees in the state. United Healthcare already manages whole person care in 23 states. So there are some disadvantages, but change is difficult for all of us. And this group and this population has been through an exorbitant amount of change. So the LME MCO stability should be there for the next 3 or 4 years. I plan to, before I leave, to write legislation for the solvency standards for the LME MCOs. I also plan to write legislation for the antiquated laws for single stream funding. A lot of folks in the legislature don't realize that the LME MCOs are taking care of the uninsured and keeping them out of the emergency rooms. When they start cutting services because they have lack of dollars, then that spigot's going to turn on and our phones are going to start to ring, and you'll see some changes that begin to happen. I have continuously tried to warn my leadership and other folks in the legislature about what can happen. And also I want to, just while I'm on the legislative route, none of these will get passed, but it'll be in a basis for the long session to be able to address it, is group home funding on a recurring basis. Those folks haven't had a raise since 92 or 3. I understand there are problems in running their business, so we want to go ahead and address it rather than doing these emergency funding of $13 million every year just to keep their doors open. And we have group homes that are closing now. We need more facilities, not less.
I can cross out that question now. Since we talked about folks about insurance, I'm flipping through. I now have One of the big questions that comes up every year, I've got to ask it, is how can we can address uninsurance by expanding Medicaid. Here we go. Medicaid expansion would especially help people who live in rural counties, and of course Secretary Cohen spoke about it, the need for working people to have access to care. What are the prospects for Medicaid expansion this year? And if not, why are you folks not doing this?
Now, I've been on board with this since day one. When the Affordable Health Act was passed, Obamacare, it allowed for it. In fact, it was a part of it until the U.S. Supreme Court made it optional to the states. It's only when the U.S. Supreme Court decision was rendered that it became optional whether the states expanded Medicaid or not. I think obviously the numbers in North Carolina, based upon research and studies, shows that it would pay for itself. So, there's no doubt that we need to do it. I think the only question is how we would do it and really a mechanism for doing it, and whether it's done more like they did it out in Arkansas or some other states. I think models are out there. I think Secretary Cohen spoke to that previously. I can say that there are representatives there today, as well as senators on both sides of the political aisle, that understand that there's a need for Medicaid expansion under the right model for North Carolina. And with that said, I think that, Senator Tucker, what are your thoughts on this?
You took the words out of my mouth, Senator Dissing.
Ladies and gentlemen, let me just say that there are two sets of statutes, if I believe, that the Republican-led legislature has passed that we will not do Medicaid expansion in North Carolina. Reasoning behind that is the insecure forward funding that was promised by the federal government. Senator McKissick was for Affordable Care Act before it imploded and cost us $1 trillion in the budget. Expansion of Medicaid, I was in the Eisenhower office building, the West Wing, with Vermont, Ohio, and Maine. Pennsylvania and Virginia and North Carolina had not expanded Medicaid. The three of us had a balanced Medicaid budget. The other two were running other three were running huge deficits. There is a way to get to Medicaid expansion without calling it Medicaid expansion. Single stream funding to the LME MCOs to take care of the uninsured and increasing that. As long as it's covered, I don't care what it's called. There are ways to go, but there is no political will that I can see in the General Assembly for Medicaid expansion at this time.
And I might simply say this. I think of somebody like Representative Lambert, who certainly supports us trying to come up with a model and a method for doing so. I think that there's a way, there's growing concern about what we do. One of the arguments that was raised in moving forward with this managed care approach to providing services to the Medicaid population is that it controlled costs. Cost was, before then, considered to be unpredictable. You might end up with a $300 million deficit one year. You might end up with a $5 million deficit, $500 million deficit.
500 million.
500 million, yes, exactly, on another occasion. And it didn't matter whether we're Democrats in charge or Republicans in charge. So with the managed care approach, you know the amount of money you're spending each year for Medicaid. You don't have that volatility. You have predictability. In that environment, even under a prior McCrory administration, there was an interest in trying to come up with a method and a procedure for doing it in North Carolina. I remain cautiously optimistic that that pathway will be found. At the same time, I also believe that it may be a political leadership in this state to do so.
I don't want to get into the Democrat-Republican thing. Floyd is a very good friend of mine. No kidding. We have debated, and we have worked together. Much of what you see in Washington does not exist in Raleigh. I know Floyd McKissick's heart, Carla Cunningham, and Pat. I just don't have that issue, and we vote together about 85 or 90% of the time. We're just in different areas on the different sides on this thing. Let me just say this to you as well. Federal government's $21 trillion in the hole. And I can tell you that I believe sooner or later, whether it be a Republican or Democrat legislature, Congress rather, that we're going to go to block grant with less money. And that's going to mean that CMS is going to take some of the tentacles out of what makes your business so complex. They need to back off. All the accounting operations and everything that the LME-MCOs and DHHS has to go through, and the litigious kind of role that's here with all the lawyers is going to have to back off, and we're going to have to get involved in our communities, ladies and gentlemen. We're going to have to get involved. Those family life centers in these churches that stay empty from week to week, they're going to have to get involved in getting their hands dirty with the poor, with those that have mental illness, and with those who are affluent that have mental illness, because this disease and the problems we have seem today not to discriminate between your social status in this country. But block grants are coming because the federal budget is looking for predictability and entitlements, and we cannot run away with budgets. You know, when I first came to General Assembly, as Floyd said, we did our budget, and then in May, Medicaid told us you're $500 million in the hole, you gotta come up with cash. That happened to the Democrats too. Now we've got a $260 million surplus in Medicaid as we move forward. I think that's close to the number, Dave, really right now where we are. So we've got a handle on this, and we're managing that piece of it. Sure, more money, and more money needs to be given and put forth, but there's got to be some efficiencies that show up that are there. And quite frankly, the LME-MCOs, despite what Cardinal did, despite what the board did, despite what their leadership did, the folks on the ground are still delivering those services at Cardinal, and they should not be, and the rest of the LME-MCO should not be covered in that same light. So as we move forward, we will have to do more with less, because I can't tell you, we can't keep going on and on and on and on. And our great-grandchildren are going to have to pay that deficit. I think housing, the gentleman that ran, African American Republican that ran for president, golly, I read his book. Forgive me, I'm having a senior moment here. He's health and urban, huh?
Carson.
Who?
Carson.
Ben Carson. Yeah, he said that if we paid $100 million a month on our federal debt, it would take us 5,000 years to pay it off. That gives you a perspective of where we are in the federal government. So while we want to tuck it under the rug and say, you know, those chickens are going to come home to roost, as President Obama's preacher said at one time. And so I say all that to say, you know, we're going to have to manage our money if we want to provide some services.
You know what? So hang on, we're going to move on because we've only got about 8 minutes left, and I've got a table full of questions. And that's for TERS. So, and I know that TERS is difficult for Senator Tucker. So you know. So I'm going to move on, and I know that this is a hot topic. It's always the elephant in the room, but we're going to move on. This is something that it's about the legislature. It's stigma's a big problem in mental illness. What can legislators do? You know, what attitude at the legislature, and what are you prepared to do to help address this stigma? What can legislators do? Representative Cunningham.
Well, when I came to the legislature, one of the things that I focused on was suicide prevention. And it was well received in the House. Matter of fact, it passed several times, and every time it got ready to cross over, it was something that happened on the other side. I don't know what that is, but I know that in the House, there's more receptiveness to having those discussions. It's a difficult subject to talk about. And I think one of the things that I was looking at this year is possibly seeing if I could get all the legislators that are on the Joint Legislative Health and Human Services Oversight Committee to sit down and look at resilience and have someone to bring the resilience down in, because we tend to focus on after the fact. Like we talk about Medicaid expansion, you know, North Carolina is a very unhealthy state. Generally, for everybody that's in it, we are overweight, we're not eating right, we're not exercising, and then we have mental health crisis, we got opioid addiction that's rampant, we got people dying every day from the opioid abuse. And if we always want to be on this side after, you know, the condition has got so bad, we're gonna always spend more money. So if we were on the preventative side, we could extend the quality of life. In the last 6 months, when people are dying, the last 6 months of when people are dying is when the most money is spent on healthcare. It's the last 6 months where you're trying to draw every straw to live, even if the life is not quality. And we need to start focusing on preventing.
So, since this is a room full of advocates, how can people effectively advocate to legislators around reducing stigma, reducing suicide, helping address opiates? What's the best way for them to advocate to you?
One thing I'll simply say is this: they need to stay proactive, engaged, involved, and approach those legislators from their districts and their communities that have their ear and let them know of their concerns. In my mind, the most significant issue that's occurred recently that's caused people to think more about mental illness is, unfortunately, the number of incidents with school shootings. And the trend that you see among all those incidences are shooters that had mental health illnesses and problems. So it's finally focusing attention on the number of counselors that we have in our schools. Those who are psychologists or psychiatrists, those who are school counselors, those who are guidance counselors, where they can begin to intercept social workers. They can intercept and understand what is going on. So I think that issue alone is elevating the awareness of mental illness in a way that it hasn't come to the forefront in the past.
Representative Black looked like she was about to say something.
A couple of things I want to say. So I'm sitting on the safety task force. We've been meeting and we've had.
This is the legislative safety.
Yes, and looking at what we're going to do to keep our young people safe in the schools. And one of the things that is not coming up as we work over and over again on this issue is what are we going to do about guns? But when I'm out in my community and I'm talking to young people, and I've been doing that now for several weeks, that's the issue that they're putting on the table. We're talking about putting more school social workers, nurses, and everybody is saying they want nurses in the school, guiding school counselors in the school. I think that's great and we need to do that. I'm going to be leaving in about 2 minutes because in my district I put together a panel from a group of people from Duke, a psychologist, psychiatrist, and a social worker, who are going to be talking with over 40 people, I'm told, waiting for me, on bullying. That is such a huge issue for our young people. And the people in McDougal Terrace who asked me to do this for them talked about the bullying. And then when you feel that you've had more than you can take, out comes the gun for some people who then end up shooting. And some of the shooters who shot around this country were students who had been bullied. And I want to go back to the Medicaid expansion, and then I'll finish, I'll hush. What I'm seeing is that we have the numbers of 390,000 to 500,000 people who are not covered in North Carolina. We can't let those people not have services and die because they don't have the correct services that they need. There is a way for us to address that, looking at the money as well.
Okay, I'm going to cut this short because we've got so many questions, we've got so little time.
Can I go back? Because I gotta clean this up. I can't let this go. Because we already stigmatized mental health enough. And I don't want it to be said that everybody that picks up a gun and go out and shoot somebody has a mental illness. That's not the case. And I want to start separating, because if you look around this room from the people that's in here, 1 out of 4 has some type of undiagnosed issue with mental health going on. We just don't want to acknowledge it ourselves.
Amen.
And to remove the stigma, we can't just associate mental health with violence or mental health with guns. We need to separate. I have to say.
So, Representative Cunningham, if that's what it seemed to be implied, let me make sure you know that is not what I implied.
Oh, no, I wasn't
And I'm-
referencing.
Oh, okay, and on the, I'm
So-
on the record for saying, let's separate the two.
So that, and there was, we got several questions, on where do legislators stand on gun control. Kids are being afraid to go to school. We're not looking to take away guns, but looking at things that feel like common sense, like background checks, limits on automatic and semi-automatic weapons, etc. Are folks, interested? Is there any appetite for that at the legislature?
I hope and trust that there is. I mean, I can't imagine why we would not be in favor of legislation that would increase the age for buying firearms from 18 up to 21. It's always amazed me when you look in the Sunday paper and you see these flyers from stores that are selling you firearms. You couldn't go in there and buy a beer, whether it's a Walmart. Of course, Walmart recently said they're going to move away from it. We're talking about bump stops. Whatever it may happen to be, I think there's an appetite for it. It's something that I've been an advocate of for many years because I was a victim of gun violence back in 1985. So, I mean, this is not something that's been a recent advent in my mind. It's something I've been a champion on for many years. And I think there's finally, as a result of Parkland and all the youthful exuberance that's out there today, we need to capitalize upon it. And we finally need to be held accountable if we don't make some changes.
So, you're speaking from the minority, do the folks who are in the majority in the legislature, do you hear about anything from your caucus?
Yes, and evil as it is, there'll be no way to stop an evil person who has evil intent in his or her heart to stop them from doing this. They will get a gun from somewhere. If they're a criminal, they will figure out how to get it. And you cannot stop it completely. And do we want to lock up our schools and our children like in prisons? And that's what's being talked about now. And gun control, just think about that. Think about gun control. You need a gun sometimes to protect yourself. I don't have one, I don't want one. But a criminal may come and kill me, it may do that.
But, Sir Representative Hurley,
Yes.
is there any appetite for any type of legislation in your caucus?
There is already legislation and laws out there that will cover all this. You cannot stop a criminal. You cannot stop someone with evil intent from doing it. A law is not going to stop that.
I guess you're throwing the ball back to me.
You spoke.
I would like to give you some flowery answer about it, but I don't think there's any appetite for any kind of legislation on gun control currently as the makeup of the legislature exists. We have to remember we had a semi-automatic ban for some 10 years when President Clinton was in office. If I recall correctly, and we did not see any drastic drop there. I think as far as the schools go, there are 2 or 3 thoughts that are there for the children. Number one, Israel has 3 different compartmental bulletproof glass that you go through. You go up to a school, you don't wear an overcoat, you take it off to come into school. You have the metal detectors, you can be searched without a warrant. Those kind of things can stop that. The other thought process that's going around the country that we heard about is where parents are stationed outside the school, believe it or not, with bulletproof vest and a taser, so that if someone comes into school shooting, that they would get to the parent before they got to the children. I know it sounds wild, but that's what some people are talking about doing. So law enforcement officers, more presence in the school, that's fine. The Parkland killing was senseless. The entire system failed. We had a background check, the FBI at the guy's house, the school not reporting violations, just a number of things that allow that young man crazy guy to commit murder to those children. So, I think there are some measures. The other thing that they do in Israel is everything's on remote lockdown. Everything's on lockdown.
I repeat, hold everybody accountable who doesn't support change.
Just short again, because we have, I think we are done with our time. We are out of time. We're
All right, Joe, just a couple closing comments before you head out the door. Number one, on the back of your program, there is a QR code. If you have a QR reader on your phone, you snap a photo of that, it's going to ask you to fill out the evaluation for the event. The organizers would like you to tell them how they did. Can we please give a round of applause?